the skills that we have acquired in Planet will be used, of course, in the clinical setting, of course. So both in the Pilastro area and in Bologna in general, in the outpatient clinics.
Can you maybe introduce yourself, your background, and your role in Planet?
Yes, I am Sabrina Berti. I am an endocrinologist and a diabetologist. I'm a medical doctor, and I work at Policlinico Sant'Orsola in Bologna, Italy, and I specialize in diabetes and obesity care. I have been present in Planet since 2025, and in Planet I enrolled part of the patients and created the medical part in the visits in the clinical study associated with the Living Lab of Bologna.
Can you tell us a bit more about this clinical study? What is its goal? What are the patients? Who are the patients?
We elaborated this clinical study that targets patients with type 2 diabetes. They also have a low socio-economic status and they live in a difficult area of Bologna, in a very populous neighborhood with a high prevalence of diabetes and also of migrant patients. We enrolled 101 patients from 4 different ethnicities, which are South Asians, meaning they come from Bangladesh, Pakistan, India, North Africans, Eastern Europeans, and then Italians. Four groups of about 25 patients per group. The goal is to see if culturally adapted diet plus physical activity effectively has an effect on glycemic control. This is the main goal, and also on weight and waist circumference. Other indicators that we look at are questionnaires for the quality of life and also metabolomics for cortisol measurement. So we have patients have done the 6 months follow-up. So we have the interim results of the 6 months, where the 12 months results will come in July as the study ends at the end of July. Patients were quite happy about the study. In general, we had a positive feedback, and many patients asked if they could continue the study even after the completion, and this was quite a positive remark of our work. We also had the dropouts, so we had 18 patients who dropped out because of work reasons, mainly. The interim results show that glycemic control actually improved in both groups of patients, because we had one group of patients, it was an open label intervention. So at the beginning of the study, the patient got to choose whether they preferred the intensive intervention, the culturally adapted intervention that maybe I can explain later, plus the physical activity, so a high-demand program, but also highly rewarding, maybe for the patient, or the standard intervention, the standard recommendation, dietary recommendations, which are the normal dietary recommendation that we do in all diabetologist visits, but with the help of a dietitian that follows us in every visit. It was an open label intervention, so patient got effectively to choose. And at the end of the 6 months, both groups improved in the glycemic control, and this is quite a beautiful result. But the intensive intervention, so the culturally adapted intervention, did not prove superior to the standard intervention. And this, of course, they are interim results, so we need to confirm that and see what happens at 12 months. But this tells us that in migrant populations or in vulnerable populations in general, we need dietary counseling and medical visits in any form are the real change, the real difference in the one that make a difference. But the patients that tried the intensive intervention came to us with really positive feedbacks. So they tried to actually do these the plates the dishes that we suggested at home. For example, for the South Asian patients, we do not have a classical diet, Mediterranean diet, when you say pasta and milk for pasta for lunch, milk for breakfast, but rice, basmati rice, spiced vegetables for lunch, goat's milk as a drink. It's an example of culturally tailored. So our dietitian spoke with them, tried to understand what they ate in everyday at home, and then tried to adapt those recipes in a more healthy, sustainable way, and a way that could improve their diabetes lifelong.
And are you the first study of the kind that works with migrants with type 2 diabetes?
No, there are other studies have been done before, but this type of intervention, so the idea of not having a diet that fits all, which is now the standard, almost the standard. We do a little personalization, but not so much in the clinical practice. Having a diet that is also culturally tailored if the patient requires it, because maybe it doesn't want, but if the patient requires it, is the first type of study that enrolls patients and tries to adapt a diet to their cultural preferences, instead of trying to force a diet into the patient, a Mediterranean diet into the patient, which is the standard. So we hope that the 12 months results will be even better, even more complete, and even showing a difference between the two groups than the 6 months results.
So you said that the patients were very enthusiastic about the study and that they wanted to continue. Did you find some solutions, some ways of continuing the study?
Actually, the skills that we have acquired in Planet will be used, of course, in the clinical setting, of course. So both in the Pilastro area and in Bologna in general, in the outpatient clinics for diabetes. Some at a meeting, a cross-fertilization meeting, we talked with some FIST colleagues that really liked the study and wanted to replicate it on a larger scale. Maybe also RCTs, so randomized controlled. It would be a great design to effectively prove if the intervention is the culturally adapted intervention is superior to the standard intervention or not. Right now, we don't have, unfortunately, the resources to continue the study in that way, but all patients are going to be followed up in general with diabetes by me personally, and but skills are gonna be used. And hopefully the study will be replicated on a larger scale by dissemination when the results will be ready, and we will disseminate them through publication, through the knowledge center. We hope that some colleagues will replicate it better also.
And I have maybe just one question.
Yes.
So about the fact that you chose migrants as your target population group. is the prevalence of diabetes type 2 higher in migrants population?
Yes.
Yeah.
Yes, especially in some migrants population, like South Asia and South Asians and North Africans, the prevalence is actually higher, very much higher than Italian Caucasian patients, both because there is a genetic predisposition to type 2 diabetes in Asians, in South Asian patients, and also for cultural and socio-economic reasons, but mostly there is a genetic predisposition in them. So far that in our clinic, almost 35% of patients have a migrant background, and the others are Italians. Diabetes is one of the diseases that is deeply influenced by migrant backgrounds. So we knew that these patients that are also younger than Italian patients, they are younger, they are leaner, and nevertheless they have the highest cardiovascular risk and diabetes progression risk. So a key finding also at the baseline that we had was that these patients are a little different from the Italian population and need to be treated maybe with more care, with more frequent follow-ups. And that's also a message to the healthcare institutions that we try to convey, that when patients are younger and they are doing maybe acceptably with diabetes, they need nevertheless to be followed up because they are more vulnerable due to their ethnicity, due to the socioeconomic backgrounds. So maybe we have to follow them more closely than maybe an Italian patient that is maybe older and less at risk than them. So that's the clue.
And can you tell us a bit more maybe about the macro level, more political level or institutional level? You just mentioned the healthcare institutions.
Yes.
What did you do in your living lab to help change the system or that is behind also diabetes type 2?
Yes, so we worked with institutions, with associations at the meso level. We worked with the association of patients, and to raise awareness, also to involve the more patients, the most patients that we could, also in the working groups that we had in our living lab. And we had a good collaboration with them that will continue in the future, and this is a good thing. For this, we had also a policy meeting on January 2025, where also the institutions were involved, and where we presented the preliminary the project, the preliminary results, and we are waiting to present them the final results to encourage them to take action about these patients. So we are hopeful that with the results that will be also presented in the knowledge center, we can influence them to do something about these patients.
Thank you very much. Is there anything you would like to say to conclude about your living lab or your experience in Planet?
I would like to thank you and all the Planet organization and the Planet consortium for all the beautiful organization and the opportunity that you have given us to tackle a problem that is often overlooked and would have not maybe been looked at for years. So I'm quite thankful to all of us, all of you.
Thanks to you, Sabrina. Thanks a lot.
Thank you. Bye.